Hi everyone, and welcome back to the channel. I'm Hafiz, a cardiologist training in London, and today I want to talk about something many people have heard of, but few really understand: the so-called hole in the heart. This phrase gets used a lot, and it can sound frightening, but it actually refers to a range of conditions where there's an opening in the wall that separates the chambers of the heart. Some of these are picked up in infancy, others don't show up until adulthood, and some never cause any problems at all. My goal today is to explain to you what we mean when we say hole in the heart, why it happens, how it's diagnosed, and what we do about it. So let's start with the basics. The heart has 4 chambers, 2 upper chambers called the atria, and 2 lower chambers called the ventricles. Normally, the right side of the heart pumps blood to the lungs, picks up oxygen, and the left side pumps this oxygen-rich blood to the rest of the body. The walls between the chambers, called septa, are there to keep these blood streams separate. A hole in the heart usually means one of 2 things: either an atrial septal defect, or ASD, which is a hole between the atria, or a ventricular septal defect, or VSD, which is a hole between the ventricles. There's also something called a patent foramen ovale, or PFO, which is a small flap-like opening between the atria that didn't close properly after birth. All of these are congenital, meaning people are born with them, though sometimes they aren't discovered until later in life. Why does this happen? During fetal development, the heart forms a simple tube into a 4-chambered organ, and the septa grow in to divide the chambers. If this process doesn't complete fully, a hole is left behind. PFO is actually very common. About a quarter of adults have one, most without ever knowing it. ASDs and VSDs are less common, but still among the most frequent congenital heart conditions. What does a hole in the heart do to the circulation? Well, it depends on its size and its location. A small defect might cause no noticeable problems at all, and a person can live a completely normal life without symptoms. But a larger defect allows blood to pass from one side of the heart to the other, usually from the high pressure left side of the heart to the lower pressure right side. This means that extra blood flows into the lungs, which can eventually strain the right side of the heart and raise pressures in the lung circulation. Symptoms vary. Children with significant VSDs may have rapid breathing or poor feeding or failure to thrive. Adults with an undiagnosed ASD might notice breathlessness, fatigue, or palpitations later in life. Some people discover they have a PFO only after experiencing a stroke that doctors suspect was caused by a blood clot crossing through the hole into the circulation to the brain. So while hole in the heart can be benign in many, it can also have serious complications in others. So how do we diagnose it? Often it starts with a murmur, an extra heart sound a doctor hears with a stethoscope. That prompts an echocardiogram or ultrasound scan of the heart. This test can show blood moving through a septal defect and assess how big the hole is. Sometimes we use more advanced imaging like transesophageal echocardiography, where an ultrasound probe is placed down the esophagus to get clearer pictures. I've done a whole video on the echocardiogram, which you can watch later. In certain cases, MRI or CT scans can add extra detail. For a PFO, we often use a bubble study where agitated saline is injected into a vein during the echo scan to see if bubbles cross from the right to the left atrium. So what happens once we've made the diagnosis? Again, it depends on the size, symptoms, and risks. Small holes that aren't causing strain on the heart or symptoms often don't need any treatment at all, just monitoring. Many small VSDs in children actually close up on their own as the child grows. If the hole is larger or if it's causing problems like right heart enlargement, breathlessness, or increased lung pressures, we consider closing it. There are two main ways to do this. One is open heart surgery, where a surgeon sews or patches the hole closed. The other is less invasive, via a catheter-based procedure where we insert a device through a vein in the leg and place a closure device like a tiny umbrella across the hole under X-ray and echo guidance. The choice depends on the type and size of the defect. For PFOs, closure isn't usually needed unless there's been a stroke thought to be related to the PFO or in some other specific circumstances. Otherwise, we just note it and leave it alone. Now, let's talk about outcomes. The good news is that treatment for ASDs and VSDs are highly successful. Patients often see their symptoms improve dramatically after closure, and the heart can remodel back towards normal over time. Long-term prognosis is excellent when problems are dealt with early. The key is picking up the diagnosis before irreversible damage is done to the lungs or right side of the heart. It's worth saying that living with a small, harmless defect doesn't mean you can't have a normal life. Many people with tiny ASDs or VSDs are completely well, exercise freely, and never need an intervention. The important thing is to have regular follow-up with a cardiologist who understands congenital heart conditions. When people hear the phrase hole in the heart, they often think of something catastrophic. But the reality is far more nuanced. It can mean a tiny harmless finding that needs nothing more than observation, or it can mean a significant condition that requires surgery or device closure. The key is recognizing it, assessing it carefully, and tailoring management to the individual. So to recap, a hole in the heart usually refers to an ASD, VSD, or PFO. These are congenital defects where blood flows between the chambers that should be separate. Some are small and harmless, others are large and symptomatic. We diagnose them with echocardiography, sometimes using bubble studies or advanced imaging. Treatment ranges from simple observation to surgical or catheter-based closure, and outcomes are excellent when treated appropriately. If you or a loved one has been told you have a hole in the heart, I hope this explanation makes things clearer and less intimidating. Always discuss with your cardiologist what type of defect you have, what the risks are, and whether treatment is necessary. Thanks so much for watching. If you found this video helpful, give it a thumbs up, subscribe for more clear explanations of heart conditions, and share this video with someone who you might think will benefit. I'll see you in the next video.